keep your hands up if it's TTR time. So there are a few of you here. I'm going to try and shorten this talk to give time for questions. So if I seem to miss some slides, don't worry, I think it's important to give time for questions. So I'm going to talk about what AL amyloidosis is, how it can affect the body, and the initial treatment, how one measures the response to treatment, and what you do thereafter. And I will try to briefly cover where things are with TTR, we should really call it A for amyloid, ATTR amyloidosis. We'll take home messages at the end. So AL amyloidosis is really two diseases. It's the underlying bone marrow disorder, so-called plasma cell dyscrasia or monoclonal gammopathy. It's really a low-grade form of myeloma, and 80–90% of patients with AL amyloidosis have got a very subtle underlying bone marrow disorder, which, if it weren't producing so-called light chain protein that formed amyloid, the bone marrow disorder would go unnoticed and not require treatment. A small proportion of patients with AL amyloid have myeloma as well, where the plasma cells are damaging the bone marrow, replacing it and preventing production of normal blood components and things. But most patients don't. So the thing, and really the problem in AL amyloidosis, in many ways, is that every single patient is different. The amyloid-forming protein, the so-called aberrant light chain, is different, is literally different in every single patient, and it behaves in different ways. Patients make different amounts of light chains. Some light chains prefer to aggregate and form amyloid in the kidneys mostly, others in the heart, others in many different organs. And really, although there are some common patterns, for example, kidneys and heart being common organs to be damaged, the disease differs in subtle and not so subtle ways in every patient. The first patient I met with AL amyloidosis was diagnosed when she was 29, before she's older than me, and she's now 75. So, it really does run different courses in different people, but it can certainly affect the heart in 2/3 or so of patients, kidney in a good half of patients, the soft tissues around the tongue and sometimes in the muscles around the face. It can affect the gut in many different ways. It can affect the nerves in the arms and legs, and very distressingly sometimes the autonomic nerves that control automatic body functions, such as opening the bowels, food moving down through the gut, control the blood pressure, which can lead to fainting and so on. And of course, the symptoms of the disease will depend on which organs have been damaged. And these are some of the common symptoms: breathlessness, which can be caused by involvement of the heart. It's actually quite difficult to know what's going on in the lungs, but that can occur as well. Swollen legs can be due to impairment of the heart or the kidneys. And of course, there are a whole variety of gut symptoms, motor diarrhea, constipation, and so on, which can occur as well. One of the common features is a tendency to bruise, because there is a small amount of amyloid in little blood vessels throughout the body. It can build up in the muscle of the tongue, which can be very distressing, and of course a variety of nerve symptoms. So the aims of treatment are to improve quality of life and to prolong life, and hopefully to prevent or at least slow down further damage to vital organs. But of course, as with everything in medicine, there's a balance between risks of treatment, and some treatments do confer quite significant risks, like stem cell transplantation, or, which is a form of high-dose chemotherapy. It has risks to the patient's life in the course of the treatment itself. So treatment decisions can be quite straightforward. They're often reasonably straightforward at first. The decision to, after diagnosis, to proceed with chemotherapy treatment. There may be some discussion about choosing to go for high-dose stem cell transplantation or to go for cycles of chemotherapy, and the latter is what is appropriate in most patients. There are many, many different drugs, and none of these were developed specifically for AL amyloidosis. We've borrowed all of these treatments from the treatment of myeloma, the malignant cancerous plasma cell disease of the bone marrow. And myeloma is much more common, at least 10 times more common, and the drug companies have been much more interested in a more common disease for rather obvious reasons. But the need for treatment is the same, although the purpose of treatment is to suppress and kill off the abnormal plasma cells in the bone marrow, to reduce or stop production of the amyloid-forming light chain protein which circulates in the blood. And fortunately, over the past 5 to 10 years, there have been many new drugs developed for myeloma, and there are new drugs appearing every few months. Our challenge in the future is going to be how to use those drugs to best effect in AL amyloidosis, where the side effects might be different than in a patient with myeloma, and to try to find the right combination of treatments. It goes without saying that a vital component of treatment is to support symptoms, to try and reduce symptoms that are caused by the damage to different vital organs. And I'll touch on some of these, and I know the next talks are going to do the same, so I'm quite brief on that. So the long and short of this slide is that stem cell transplantation, a single dose, high-dose chemotherapy, is a possibility, a reasonable possibility for first treatment in perhaps 20% of patients. The other 80% have either got damage to different organs, the heart and kidney, which would make that too dangerous, or else they're simply older or more frail, which would make it too dangerous. Initially, stem cell transplantation was thought to be the great new wonder treatment, but in the early days, many patients died during this treatment. We now know much more about the situation, and most of that is not performing stem cell transplants in people who have got particular features, for example, notable cardiac involvement, or those who are older, and so on. Who's had put your hands up again with AL amyloid, please. And keep them up if you've had a stem cell transplant. Well, that's probably 20% or something, so it would seem that was the right kind of figure. Anyway, lots of different drugs are available to suppress the plasma cells, and these are given generally about monthly, usually in combination with dexamethasone, which is a high-dose steroid, which acts in this situation as being a chemotherapy drug, and it boosts the effect of the other chemotherapy drugs. But sadly, the dexamethasone is actually responsible for many of the unpleasant side effects: fluid retention, mood changes, difficulty sleeping, and many day-to-day distressing things. But in the UK and I think Australia, most patients are getting a combination of Velcade, dexamethasone, and cyclophosphamide as their first treatment. But there are a whole host of other treatments, some of which, like this Revlimid, which is also given with a steroid, can be given sort of long-term. They have an effect on suppressing the plasma cells, and one would continue them as a form of maintenance treatment. But there are many drugs, and the precise combination that's offered will depend on many particular symptoms. For example, Velcade, which is a fantastic drug, can cause a painful neuropathy, and therefore if a patient already has neuropathy due to amyloid, one would be at the rather cautious about using it. Won't say a lot about stem cell transplantation, but I mean, it's essentially a form of high-dose chemotherapy where a single blast of chemotherapy is given to try to kill off most of the bone marrow, including the bad plasma cells, after which the patient's so-called bone marrow stem cells are given back in a blood transfusion and home in on the bone marrow to form a hopefully healthy bone marrow. And I think if one was offered this, if you are deemed eligible in the 20%, I would think very seriously about proceeding with this, because patients, if the treatment is over and done with relatively quickly compared to many cycles of chemotherapy, and those many patients who respond well to this can expect to remain in remission for many years without the need for further treatment. You are all probably familiar with the free light chains, because measurement of free light chains in the blood is the best way of tracking what is going on in the bone marrow. There are various other blood measurements as well, and urine measurements, and sometimes scans and things, but measuring the serum free light chain is actually measuring the amyloid forming protein in the blood in the best possible way. And response to treatment can be thought of in two different ways. Firstly, what's going on in the bone marrow as the chemotherapy killed off the plasma cells in the bone marrow, i.e. reduced production of the free light chains. And one will continue to monitor the blood free light chains kind of endlessly to see at what point it may be returning. And then there's the so-called amyloid organ response. So if the heart or kidneys have been damaged by amyloid, we want to track what is going on in those organs and hopefully very gradually see some improvement in the function. The problem is that once you switch off the tap, in other words, you stop the production of more free light chains, the body takes many years to clear away amyloid naturally from the organs. And organs can start picking up before much amyloid has been cleared away, so long as you're not making new amyloid. But unfortunately, it can take a long time for there to be any recovery in kidney function, and even longer for the heart. The SAP scan is something we developed in the UK, which is not available commercially, which is, SAP is a blood protein, which everybody has, which binds to every different kind of amyloid in every organ. We radio label SAP, we make it radioactive, inject it to patients, and it localizes it on amyloid, in the amyloid in the kidneys, the liver, or wherever it is. It's not good for the heart, which is moving, but we perform SAP scans and can measure the amount of amyloid in other organs and the whole body load. And this shows amyloid in a liver. This is a picture of a liver with radio-labeled SAP there. And you can see that it looks different in 12 months. There is much less amyloid already in 12 months, and we can't see any at all by these means after 2 years. So this is a patient who's had chemotherapy, they're no longer making light chains, and the body has already cleared away naturally the amyloid in the liver. The liver is rarely a serious problem, and unfortunately the liver is the place where the body is best and quickest at clearing away amyloid. It clears it away much more slowly in the kidneys, and then much more slowly in the nerves and the heart. But there is a process of natural clearance that's going on. The problem being that when a patient presents themselves with a new diagnosis, they are making amyloid more quickly than the body can get rid of it. So ultimately, we would like as doctors to see your symptoms improving.